What I'm going to do is over the next couple of minutes is actually to provide a quick overview of atrial fibrillation for my next two speakers who is going to talk about more in depth in our country specific. So I think this ECG is definitely much easier than what Prof. Chan has shown. I think in our basic medical training, I think just by having a quick look at the ECG, I think we can diagnose atrial fibrillation. And yet, this simple cardiac arrhythmia actually sort of, in high-risk patients, actually predispose them for getting a high risk of stroke. In fact, patients who actually have atrial fibrillation is 2 to 3 times getting a chance of stroke. But more than that, I think their chance of getting disability and also cardiovascular death is actually much higher. And in Asian country, in some country, of course, with a good healthcare facility, we can manage. But in some country, unfortunately, once the patient had a stroke as a result of atrial fibrillation, the family member actually have to take care of the patient, and this actually is a huge economic burden. Warfarin has always been the winner in preventing stroke among patients with atrial fibrillation compared with even aspirin or even aspirin plus clopidogrel. This has actually changed when we actually have 4 direct oral anticoagulant, which is dabigatran, rivaroxaban, apixaban, and edoxaban. In these 4 pivotal trials, we actually shows that the new oral anticoagulant is actually superior than warfarin in preventing stroke and systemic embolism. As you can see here, the 4 trials, actually for the first time, they are either superior or as good as warfarin in preventing stroke among patients with atrial fibrillation, especially in ischemic stroke, has been shown in dabigatran 150 twice a day. I think the other one more important is whether it's safe compared with warfarin. As you can see here, as far as major bleeding is concerned, we are seeing less major bleeding or equivalent safe compared with warfarin. But I think the most important advantages with the direct oral anticoagulant is what you can see here. We actually definitely have much less intracranial hemorrhage compared with warfarin. As you and I know, those patients who actually have intracranial hemorrhage, they are actually much higher chance to pass away. In fact, 50% mortality rate has been actually reported with those patients who came in with intracranial hemorrhage while they are on oral anticoagulant. DOAC is definitely as good as, if not better, compared with warfarin, and multiple trials actually have shown in all these various settings. For example, post-PCI, ACS, AF ablation procedure, cardioversion, and now we also have reversal agent for both, for all the direct oral anticoagulant. However, direct oral anticoagulant is actually not winning all the competition, right? For example, in Realign trial, when we actually tested high dose dabigatran in metallic valve, it has been shown that warfarin is still better compared with warfarin. And recently in mitral stenosis, rheumatic mitral stenosis, again, oral anticoagulant, the newer oral anticoagulant is not as good as warfarin. So this comes to the summary of what ESC guidelines have actually updated. Direct oral anticoagulant should be used in most patients with atrial fibrillation, all right, except in the setting of metallic valve and also moderate to severe mitral stenosis based on all the clinical trials that we have seen. And switching to DOAC from warfarin is what is actually being recommended if we cannot maintain a good TTR with warfarin, and this received a class 1B recommendation from the ESC. I think this is a very interesting data coming from Taiwan of how the DOAC actually changed the trajectory of stroke patient. As you can see here on the bottom in various color, starting from blue, yellow, green, and pink, when the newer oral anticoagulant has come to the Taiwan market, while the original in the first part is actually only warfarin. As you can see here, with the increasing use of DOAC, you can see that on the top of the line, total number of stroke, mortality, and intracranial hemorrhage actually has been shown to actually being reduced. I think this is a very nice diagram to actually tell us that how the newer oral anticoagulant actually changed the trajectory of patient in a national level. I think this is an updated guideline. As you can see here, DOAC is actually have a class 1 recommendation, and you only use the old warfarin if you can provide a good TTR more than 70%. I think most of the countries in South Asia or Southeast Asia definitely have DOAC available, but I think one of the challenges I have faced as in Malaysia is concerned is the use of low dose. All right, they actually have very specific dose reduction criteria according to body weight, age, and kidney function, for example. In clinical trial, using a lower dose is actually not common, as you can see here. Blue color is those patients who are actually being given lower dose in clinical trial, while the yellow portion is those in clinical trial who receive the appropriate dose or slightly higher dose. But in various registries, as you can see here, blue color and red color is the wrong dose, either is too high or too low according to patient criteria, and definitely the appropriate dose usage is definitely much less compared with what you see in clinical trial. I think this is some of the challenges that we face, especially in our Asian patient, because we always thought that the Asian are smaller, the Asian should be using the low dose, which unfortunately in clinical trial and in all this meta-analysis, which is actually not true. Underdosing actually have no impact on major bleeding, and in fact it actually increased the risk of stroke and systemic embolism. So I think the ESC guideline has also mentioned it, and to make sure that we actually using the correct dose for the correct patient with the appropriate clinical criteria. Although we have a lot of data coming from direct oral anticoagulant, however, there are still few scenarios that we do not actually have the answer yet. So I divided into three parts that I think we still have not really have a good answer whether the DOAC is definitely superior compared with the warfarin. I think the first one is definitely what we see in a lot of our practice. What are we going to use if the patient actually have end-stage renal failure or the patient is actually on dialysis? I think first thing that I want to highlight is, unlike patients who have normal kidney function, those patients who have dialysis or end-stage renal failure, warfarin did not really actually protect them from getting a stroke. This is one of the biggest registry looking at patients who actually have end-stage renal failure, comparing for those who are actually on OAC versus not on OAC. As you can see here, the stroke is actually not less for those who are taking warfarin, but the bleeding hospitalization is definitely much more higher. And we don't actually have any data for patients who are actually on end-stage renal failure giving DOAC. As you can see here, we do have 3 clinical trials, but looking at the number of patients that actually recruited in the clinical trial, you can see that the number is actually very, very small, and we don't actually have come to any conclusion as far as the safety and the efficacy is concerned. In fact, if you actually look at the multiple society guidelines, they can't even agree with each other whether we should use DOAC or not. In American Heart Association in 2019, so again, it's actually based on very limited safety data, while ESC, we don't even mention a single word as far as how are we going to deal with DAC, OAC among patients with end-stage renal failure. I think the briefest people in the world is definitely the nephrologist, who actually recommended to say that the nephrologist should be the one who actually make decision as well as primary prevention of stroke among patients with end-stage renal failure. My personal practice essentially will be a very individual decision. In fact, no OAC might be an option. In fact, the newer clinical trial, beside comparing them with warfarin, DOAC, no oral anticoagulant is actually one of the arms in the clinical trial. LAA occluder might be a good choice or some option for this group of patients. The second issue that we still do not have answer is definitely coming from device-detected atrial fibrillation. Right? Most of the data coming from DOAC is about clinical atrial fibrillation. Device-detected subclinical is defined as atrial fibrillation or atrial high rate episode detected on implantable devices, example pacemaker or consumer wearables. So common things will be what we see among patients who has implanted a pacemaker. If they actually have atrial high rate recorder, then the pacemaker interpret it as something that is atrial high rate, and we look at it is most likely possible atrial fibrillation. and whether we should anticoagulate them or not to prevent them from getting a stroke. However, the clinical data has not been helpful. These are the 2 PIC studies that actually has published on as far as efficacy to prevent stroke is concerned. It's definitely favor the DOAC, especially in Atrial study, but with the cause of increase of major bleeding among this group of patients. So we do not actually have an answer for this situation. It's still a shared decision making to decide whether the stroke versus major bleeding risk among this group of patients. The last part is that we have not really have an answer yet is whether we actually can stop anticoagulation after successful AF ablation. In the latest guideline, the ESC is still recommending that we should continue oral anticoagulation according to the Chatwa score and not about the success of the AF ablation procedure, class 1C. However, in ESC this year, we actually have a clinical trial to actually specifically looking into we should continue the anticoagulation after successful ablation of the atrial fibrillation called alone atrial fibrillation. These are done among patients who actually have Chatwa score more than 1 or more than 2. They still use the old Chatwa score. And how do you define whether they have successfully ablated? Is no recurrence of atrial arrhythmia for 12 months in at least 24 to 72 hours ECG recording, for example, like Holter. The clinical outcome are looking at net adverse clinical event, which is a combination of stroke, systemic embolism, and major bleeding. And what you can see here in this group of patients, those patients who actually in the yellow line, when they actually have stopped the oral anticoagulation, they actually have less primary endpoint compared with those who actually being continued on oral anticoagulant. So this is somehow the first study that actually show us that in contrast to what ESC guideline has mentioned, this clinical trial actually has shown that the stopping anticoagulation is possible after successful ablation. But I think the data is a bit small. Maybe I will let the moderator to decide what is the best way. And again, it's a bit doubtful because as far as the endpoint is concerned, you can see that the number of stroke and the number of major bleeding is not a lot. For example, stroke, there's only about 5 or 6 cases of stroke in this clinical trial. So whether this can translate to our practice or not is still a huge question mark for us. Again, shared decision making, low risk patient might be you want to consider anticoagulation. But however, as far as my practice is concerned, continuing anticoagulation is still what I'm doing despite the publication of alone AF study. In summary, ladies and gentlemen, I think definitely the direct oral anticoagulant definitely have changed how we practice as far as stroke prevention among patients with atrial fibrillation is concerned. The newer or the direct oral anticoagulant is the way to go based on the clinical data and also from the society guideline. I think most Asian countries, their local society guideline has also translated this into their guideline. But we still have a lot of unanswered questions as in how best to actually use the DOAC in this few situations, especially end-stage renal failure. And we do not know whether we actually can stop oral anticoagulation after successful AF ablation. With that, thank you very much.